Hello, I'm Dr. Guy Yatros, and welcome to this edition of Dental Sleep Medicine Insider magazine. Today I'd like to talk about taking the 3D bite and utilizing in particular the George and the Pro gauge. Now I know a lot of you are familiar with these bites, but there's still questions that come up in a lot of our courses about this, so I'd like to make sure that you understand how at least I do this in my practice. Before we look at the gauges themselves, let's talk about what we're trying to accomplish. We're trying to do two things. One is measure the range of motion of the patient, and the other is to take a bite in 3 dimensions where we'd like our device to start. So let's talk about the range of motion first of all. Let's don't even look at the gauges while we're thinking about this. What we're really trying to accomplish is measure how far back the jaw retrudes to how far forward if these were the incisal edges. We're trying to measure that full range of motion. This really has very little to do with CR, CO, and occlusion. It has to do with the movement of the jaw from the most posterior to the most protrusive movement. So in other words, again, we're trying to measure how far back the jaw drops when the patient's asleep at night to how far physically forward they can measure it. So this is what we're measuring. What we have to do is have a reference point. Our reference point for this measurement are the incisal edges of the teeth. Both gauges work the same way in that regards. They use the incisal edges as a 0 point. That's the reference. The moment that you start retruding the jaw, they measure that movement in negative millimeters. If we protrude the jaw, it measures that movement in positive millimeters. So in a typical range of motion of 10 millimeters, we may get a reading from 0 as the patient goes back to maybe something like -5 we're going to use today as our scenario, to as they go more forward to +5, -5 to +5. So that's 10 millimeters overall. 5 negative plus the 5 positive is a total of 10 millimeters in total range of motion. So that's what both of these gauges do. And then we're going to pick a place in 3 dimensions, both protrusion and how open we want the jaw to take the bite. So let's talk about that for a moment. Where do we want to start this device? Well, we really don't know because everybody responds differently. The only way I know that's fairly predictable, if you want to learn about that, come to our symposium in February. Dr. John Rimmers will be talking about the matrix system that can measure this before we make our devices. Other than that, we really have to kind of estimate it and start conservatively and move our devices forward as we both adjust for symptoms and sleep testing results. Typically, I like to start my patients between 40 to 60% of their maximum protrusion. So 40 to 60%. So let's just call it right in the middle, 50% in that scenario. If the patient went back 5 to +5, then in this particular case, edge to edge, 0 on either one of these gauges would be half of that distance. If you want to be more conservative, you do it at -1 or -2. Want to get a little more aggressive, you do it +1 or +2. But that's where we start these devices, and then after we deliver the device, we adjust it based on symptoms. We move it more forward. That's why we're conservative where we start it in the backward position, the retrusive position. And once our symptoms are addressed, we measure the outcome of the AHI and other factors with either ambulatory or PSG testing. So we're going to know where we are when it's all finished. So that's the 2 concepts, measuring forward and backwards, the full range of motion, and where we take the bite. The one thing I haven't talked about is how open do you take the bite when we do the bite as well. Well, that depends on the device you're going to do, but you need to have enough clearance in the back, all the way around as a matter of fact, for all the acrylic or whatever the device is made out of on both arches. Typically, we need a minimum of about 3 millimeters with most devices. Some need over 5 millimeters. So both the Pro and the George gauge come in different verticals so that we can adjust that. So I'll talk about each of them a little separately, and we'll talk about their vertical components as we're looking at this. So let's talk about the George gauge to start with. The George gauge has 2 screws. The bottom screw, all it does is allow a secure fit over the lower. So all you have to do is move it to where it snaps over the lower teeth and then gently tighten down the lower screw, and it secures it there. Now we have 4 choices when it comes to bite forks. We have 2 tannish color and 2 white bite forks that we can choose from. So one size is the size of the arch, the other is a vertical. When it comes to size, believe it or not, I usually choose these narrow ones because they just kind of sit with inside the arch sometimes and they just don't get in the way. So I prefer the narrow one, and most of the time I prefer the white bite fork because the white bite fork is 5 millimeters thick versus The tan one is 2 millimeters thick in the incisal edge. So if we use the white bite fork, we're going to have typically about 5 millimeters of clearance in the incisal edge of the teeth. So I'm going to put the white bite fork on, and again, here's how we look at the range of motion. We have the patient go forward, and we have the patient go back. Patient goes forward, and the patient goes back. And as you can see on the gauge, as they go forward, we get a positive reading of about +5 there, and a negative reading. So again, both gauges are going to work the same. If we're going to take the bite, we're going to secure that down at about the 0 mark there. So I put it at 0, put it in place, and that's where we might take our bite. But we want to double check and look in the back, take our cheek retractors and look, is there enough clearance back here for our material that we're going to have for whatever particular device we use. Okay, well, the Pro Gauge works very similar. The Pro Gauge has essentially 3 parts to it. I'll take it apart here. We have the bite fork that goes to the lab, and then we have these bottom pieces that are basically 3 different thicknesses. You can see on the edges of those, maybe if you can see at the camera, there are different thicknesses. We have a 6, a 9, and a 12 millimeter vertical component for where we take our bite. So again, this is making sure we have the adequate clearance for our materials. So with this one, you put the Pro Gauge together and snap it together as so. And I'm going to start with this one. Typically with the Pro Gauge, I usually recommend that we have the 6 millimeter bite fork, which if I can get it together correctly, which I just did, there we go. And we put the screw in here. The 6 millimeters is very similar. For most cases, that's going to work for you. If you need a higher vertical, you can start with getting the 9. Very rarely do we use the 12. And then we put the bite fork actually on, like this. And again, it works very similar to the George gauge. We put it in place with the screw loose, and the person protrudes, we get a positive reading. They retrude, we get a negative reading. So forward and backwards, we get a very similar reading. In this case, a -5 plus 5 would be 10. Again, we can use either one of these gauges to take the bite. I use the George gauge more often than I do the Pro Gauge, so I'm going to show you how you take the bite now. Again, we verify there's enough room. And I used to put the material on here and then have them bite down. But the problem is the patient can bite off to the left or right, which can have really negative effects long term for the wearing of the device. So we want to make sure they bite straight each time. And so what I typically do is put it in the mouth and have the patient bite up and down 3 or 4 times and make sure their jaw is biting the same way in the same position. The patient says, yes, I'm in the feel that's normal for me. I feel like I'm not left or right. Then I tell them to hold on. Okay, again, we have this at 0 in this case. And instead of putting the material on there first, I just squirt the material around the bite fork. And it works just as well in the mouth as I'm going to demonstrate here. You squirt it in, and if you just squirt it around the material, around the bite fork, and then take your patient, and typically if we squeeze it like this with our gloves, obviously, against the cheek, it's going to go right into in between those teeth. And we're not going to have to worry about the bite going off to the left or right. I use 45-second bite material, whichever kind you like to use, but use the short setting. It seems to work quite well for you. So we'll give us just a second to set, and I'll show you what the bite looks like when we're finished. All right, 45 seconds or so later, we just have the patient open, and again, we take it off here, and you loosen the top screw. Do not send this part to the lab or the other part with the Pro Gauge. You just send this part to the lab. And we want to verify 2 things. You put it back in place, and I put it in and make sure it just seats with no bouncing on the lower arch. And then I put it on the top arch, clunk. Just no squishing or moving around at all. And then I have the patient bite down, and I say, listen, this is where your jaw is going to start. I know there's a big mouthful of stuff here. I understand that, but how does that feel as far as where your jaw position? You feel like you're in the middle? You feel like you're comfortable? Can you tolerate that for the night, you think? And typically they'll say yes. If they don't, maybe you did get too aggressive and you might want to back it up a little bit. Again, that's all we send to the lab. That's all there is to using the Pro or the George gauge to measure the range of motion and take a 3D bite. We hope this has been beneficial. Thanks for tuning in to the Dental Sleep Medicine Insider Magazine, and let us know if we can help you if any of your dental sleep implementation needs, and we hope to see you at our symposium as well in February of this year. Thanks a lot.